Cardiovascular disease complications is the most discussed complication in diabetes, but renal complications are relatively neglected part of it. And there has to be some interconnection between these two because you can't compartmentalize things in a human body. And to throw more light on this interrelation between the cardiac failure and renal dysfunction, we have a speaker from Bengaluru, Dr. Chitra Selvam. She is Associate Professor of Endocrinology at MS Ramaiah Medical College, Bengaluru. She did MBBS in 2004 from Bangalore Medical College and MD Medicine in 2009 from Madras Medical College. She finished her DM Endocrinology in 2004 at Calcutta. Then she was AV Gandhi Award for Excellence in Endocrinology in 2015. In RSSDI, she received Young Investigator Award in 2017, and she has got more than 30 publications in national and international journals. Over to Dr. Chitra.
Thank you, Dr. Ajit, for that kind introduction. Thank you, Dr. Bansi Sabu, Dr. Sanjay Agarwal, and the organizing committee of RSSDI for giving me this opportunity to share the stage with you today. And the topic given to me is the vicious circle of diabetes, heart failure, and renal dysfunction. So, this is the outline. I'm going to begin by stating the problem and then talk about the relationship between type 2 diabetes, heart failure, and CKD, and then zoom in to understand the bidirectional interplay between CKD and heart failure, as pointed out by Dr. Ajit. And then we'll move on to see what the path ahead might look like. So, beginning with the interplay between type 2 diabetes and heart failure, this audience needs no introduction to be told that cardiovascular disease is the leading cause of mortality in patients with type 2 diabetes, and up to 1 in every 3 individuals with type 2 diabetes is cardiovascular disease. And there is a 2 to 5-fold increased risk of heart failure in patients with type 2 diabetes. Please note that I'm using cardiovascular disease and heart failure interchangeably, and I'll explain soon as to why I'm doing that. And this is exactly how. So move your eye to the left corner of the slide, which starts with insulin resistance. You move on to the onset of hypoglycemia in the situation of relative insulin deficiency. And we know that hyperglycemia brings with it increased risk of coronary artery disease, which can lead to loss of large sections of heart tissue in the form of a myocardial infarction, secondary to which you can have reduced ejection fraction of the heart failure, what is referred to as heart failure with reduced ejection fraction. But another lesser known entity, which is being spoken about of late recently, is the entity of heart failure with preserved ejection fraction. And this is also known to occur quite commonly in individuals with type 2 diabetes and is primarily related to a microangiopathy of the smaller blood vessels supplying the heart, which leads to endothelial dysfunction, which leads to sarcomere stiffness and fibrosis, leading to heart failure again. But in this section, it's preserved ejection fraction. Now, that's one way of how diabetes leads up to heart failure. But with the onset of heart failure, notice that there are a whole cascade of compensatory mechanisms which are kicked off, predominantly stemming off from the activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system, both of which are at the beginning of it all compensatory mechanisms to keep us going while we have heart failure. But in the long run, they turn out to be maladaptive and tend to worsen diabetes and diabetes-related outcomes, primarily because presence of heart failure induces a state of chronic inflammation downstream to activation of sympathetic system and the RAS system, which in turn leads to increased insulin resistance, which makes management of diabetes a little bit difficult. That's about how diabetes and heart failure can feed off each other. And coming to the effect of diabetes itself when it comes to heart failure outcomes, this graph is to show you over the follow-up of about 3.5 years, the presence of diabetes increases the risk of CV death in individuals who have heart failure. The risk is greater in individuals who have heart failure with reduced ejection fraction as compared to individuals who have preserved ejection fraction. I think nothing new here, right? To know that the presence of diabetes worsens outcome for individuals with heart failure. Moving on to the interplay between type 2 diabetes and chronic kidney disease, I think this also is a topic that we are very, very aware of. We now know that CKD can affect up to 40 to 70% of individuals with type 2 diabetes. We also know that diabetes and hypertension together contribute to up to 80% of all individuals with end stage renal disease. In fact, it's a neck to neck race between hypertension and type 2 diabetes as to who is the leading cause of end stage renal disease. And the presence of diabetes in an individual with CKD again increases the risk of all cause mortality, right? So, this is again something that we appreciate. But another point that we need to appreciate is the most common cause of death in individuals who have CKD secondary to diabetes happens to be cardiovascular disease, right? So, that is another thing that we need to keep in mind while we go about caring for individuals who have CKD with diabetes. Now, the pathway downstream to the onset of diabetes to the end result of diabetic kidney disease is something that this audience is very, very familiar with. And I'm not going to pause here to explain the flow of events. But there are some key changes which happen in the structure of the nephron, which then results in progressive renal disease. Some of the key changes at the level of the glomerulus are the fact that there is basement membrane thickening, there is loss of podocytes, there is increased mesangial cell and expansion of the mesangial matrix, all of which lead to production of more and more pro-fibrotic and pro-inflammatory cytokines in the local milieu of the glomeruli itself, which affects the functioning of the kidney itself. Again, I'm pausing to highlight that the onset of kidney disease, be it in the form of albuminuria or in the form of decreasing GFR, does increase 10-year mortality. So this is again to be kept in mind. Moving on to the interaction between CKD and heart failure now. Now, this is probably the aspect of the interplay which is not very often spoken about. And it's important to understand that if you take individuals who have just heart failure, not due to diabetes, you will notice that up to 2/3 of those individuals have CKD. The risk of cardiovascular death increases in individuals with heart failure with every percentage drop in EGFR. Now, presence of CKD in individuals who have heart failure increases their mortality significantly. Now, the effect of CKD on the heart is easy to understand if you look at individuals who are young and healthy, but who have CKD due to any other reason or cause. Documented evidence is there to suggest there is hypertrophy of the left ventricle. There is also onset of myocardial fibrosis, all of which have known to improve or even reverse right after renal transplantation. So that highlights that even without the presence of type 2 diabetes or coronary artery disease, CKD itself can worsen functioning of the heart itself. And this is the interplay that I'm going to zoom into a little bit more to understand mechanisms of this interplay. So the tiny subset of individuals who have diabetes, who have CKD, and who have heart failure is who we're going to talk about today. And we've understood now that this is an extremely vulnerable population with very high risk of worsening hospitalization, and morbidity and mortality. But before we went on to this vortex of circles, it is important to understand there was a long arc of hope, which we should all be capitalizing in. So this arc is to highlight that at the end, we might end up with heart failure, coronary artery disease, and CKD, but the leading up pathways for both CKD or cardiovascular disease / heart failure are pretty much the same risk factors, whether it is diabetes with coexisting hypertension, obesity, or dyslipidemia. And the opportunities for us to intervene and to move this arc back or to flatten the curve are numerous, and this is something that we might need to capitalize on. So this is a pictorial representation of the vicious circle that we spoke about, how they feed off each other, that the presence of diabetes can lead to both heart failure or diabetic kidney disease. But I'm going to now zoom into the interplay between diabetic kidney disease and heart failure in specific detail. Now, to try and understand the mechanisms tying up these two syndromes, they have been categorized into 5 cardiorenal syndromes to make understanding of this easier. Type 1 to type 5. Notice that type 1 and type 3 are acute, and type 2 and type 4 are chronic, and type 5 is secondary cardiorenal syndrome. I'll start with secondary simply because it's a whole lot easier. Type 5 cardiorenal syndrome is where you have another insult which is external in the form of a systemic insult. It could be in the form of sepsis, or it could be in the form of a septic shock, secondary to which it affects the functioning of both the heart and the kidney. So in this situation, the treatment is quite simple. You treat the systemic insult and hope that the renal and the cardiac parameters normalize after that. Moving on to the other 4 types of cardiorenal syndrome. The first 2 cardiorenal syndromes are where you have a primary cardiac event or primary cardiac pathology, which is leading to kidney disorder. So in type 1, it is acute. In type 2, it is chronic. So in type 1, you have acute heart failure, which leads to acute kidney injury. Most commonly, because in the acute setting, hemodynamic, minus humoral are the ones that leads to this kidney dysfunction. Whereas hemodynamic humoral changes to more fibrotic changes or apoptotic changes. If you move on to type 3 and type 4, renocardial syndromes, here the primary pathology is at the level of the kidney, which then goes on to affect the functioning of the heart. So this is actually renocardiac syndrome. Again, in the acute setting, in the presence of acute kidney injury, there are numerous factors which can lead to this syndrome to develop, beginning with salt and water retention, or the uremia, which is caused due to acute kidney injury, which could be toxic to the functioning of the heart. And in type 4, you have a myopathy which sets in because of the chronic effects of these changes. So traditionally, for the cardiorenal interaction, it was believed that if you had heart failure, there was decreased cardiac output, so there was low renal perfusion, and thereby there was increased renal vasoconstriction, and which led to acute tubular necrosis and thereby worsening kidney injury. But this is an extremely simplified version of the tying up of heart failure and kidney outcomes. With the presence of type 2 diabetes, you know that in type 2 diabetes, there's already a baseline renal tubular hypoxia which is going on, which is likely to get worsened. But now this interaction has been broken down into further detail, and it is now beginning to be understood that probably the low perfusion of kidney is not the only reason. Probably the predominant component which plays a role in this situation, where you have acute heart failure or even chronic heart failure for that matter, is the fact that there is increased central venous pressure, which gets transmitted down into increased renal venous hypertension, which in turn then is felt right through the glomeruli, and there is increased intraglomerular hydrostatic pressure, which leads to decreased net filtration pressure, and there is decreased transrenal perfusion pressure. So these are in the acute settings. Another cascade which happens is the cascade related to the compensatory hormonal and inflammatory responses which happen related to increased sympathetic nervous system and increased RAS system, all of which at the end of the day lead to decreased EGFR. Zooming into the neurohumoral mechanisms, the predominant mechanisms riding out of heart failure is an increase in sympathetic system activity or the RAS system activity. So when there is increased angiotensin 2, you have systemic vasoconstriction. So that could at the end of the day lead to decreased renal perfusion. Also, we know that aldosterone can, in the meantime cause sodium and water retention, but we also know that it also has powerful fibrotic potentials through galactin 3 levels. So that is one of the reasons why it can lead to both renal fibrosis as well as cardiac fibrosis. And this is the model which is likely to explain how both heart failure and kidney disease can feed off each other, especially in chronic states like in situations related to individuals with diabetes. The certain specific mechanisms which are probably more related to renal disease leading off to heart failure are these two mechanisms. This is cardiorenal anemia. We know that in the presence of kidney failure, anemia is very common. We also know that anemia is a significant risk factor for worsening heart failure. The anemia in the context of CKD is due to numerous factors. It could be because of decreased absorption of iron from the intestine. It is also attributed significantly to the fact that there is decreased erythropoietin secretion, which comes from the peritubular cells, and also the fact that individuals with ESRD are likely to get numerous phlebotomies and HDs done, which is likely to exacerbate anemia. The other important aspect, which is probably not spoken about enough, is the presence of CKD MBD or mineral bone disease. In CKD, there is decreased ability of the kidney to excrete phosphate, so there's increased phosphate level in your blood. In an attempt to compensate to eliminate the amount of excess phosphate, there is increased PTH level and increased FGF23 levels, both of which are known to be associated with worsening fibrogenesis or increasing vascular stiffness and calcification. It's now very clearly understood that hypophosphatemia and increased PTH levels are the non-traditional risk factors for worsening cardiovascular outcomes. Along with this, if there is lower activity of 1-alpha hydroxylase secondary to CKD, there is decreased active vitamin D, which leads to decreased intestinal calcium absorption and decreased calcium availability, which at the end of the day does affect cardiac functioning. So these are the two other specific mechanisms by which CKD can feed off heart functioning. So quickly to summarize the mechanisms, they can be broadly divided into hemodynamic mechanisms, neurohormonal mechanisms, and cardiovascular disease. Of course, I've not paused to talk about the inflammation and the increased cellular immunity aspect, which is common to all pathways leading off from type 2 diabetes, but anemia and mineral bone disease are also factors which uh, feed off the interplay between kidney function and heart function. And another very, very important aspect of the increased risk of all cause mortality in individuals who have diabetes, CKD, with or without heart failure, happens to be the serum potassium. And very interesting finding here that the relationship seems to be U-shaped when it comes to probability of mortality in individuals with diabetes and CKD with or without heart failure. When your potassium levels are going lesser than 3.5, the mortality rises steeply, as you can see, even as the potassium levels go higher beyond 6. And of course, in individuals who have both diabetes, CKD, and heart failure, the mortality is much, much higher than in individuals who have just one of these two conditions. Hypokalemia is quite common in this vulnerable set of individuals because diuretics is something which is used extensively in the management of heart failure. And RAS blockade is also something which is done very often. And these are two drugs that we need to keep in mind while we look at serum potassium, while we take care of individuals. Quickly, just gleaming through the principles of management. So when it comes to nutrition and lifestyle changes, there's something called as the obesity paradox in heart failure at least. Individuals who have a BMI greater than 35 tend to have greater mortality when it comes to heart failure. But any individual who has a BMI which is lesser than 35, in that set of individuals, people who are obese tend to do much, much better when it comes to heart failure outcomes than in individuals who are cachectic or even in normal BMI range. So we need to be careful about the protein restriction or let us say calorie restriction that we advise in this subset of individuals. Cachexia does worsen outcomes both for CKD and for heart failure. So that's something you will have to think about and negotiate with your nephrologist to decide the optimal protein intake for your patient. optimizing iron and vitamin D levels, and of course, blood pressure, dyslipidemia, and glycemic control. When it comes to specific agents which have now probably have evidence to alter the progression of these vicious circles would be SGLT2 inhibitors. We're sitting on a wealth of information today, which have come out very recently in the last couple of years. We have data from DAPA-HF to show that in individuals with heart failure, use of dapagliflozin did decrease cardiovascular incidence of outcomes, did also show that there was an improvement in renal outcomes, but the renal outcomes was a secondary endpoint. Credence also showed that in individuals who had EGFR, which was lesser, there was decreased hospitalization for heart failure. We're also sitting on data which is just out with DAPA circadian emperor. But probably the key is this, that in all the trials which have included individuals with heart failure, the renal outcomes are secondary outcomes. And in all studies which have included individuals with CKD, the heart failure outcomes are probably secondary outcomes. Now, designing studies which are including individuals with type 2 diabetes and heart failure with specific outcomes of the renal studies are probably what is required to strengthen recommendations to now lift the cutoffs of EGFR for use of SGLT2 inhibitors for EGFR, which is less than 45. So for now, it's not safe for us to use SGLT2 inhibitors in individuals with EGFR less than 45 or use of SGLT2 inhibitors in the setting of acute heart failure. So that's something that we still need to remember. GLP-1 receptor analogs have not been shown to worsen heart failure, but have not been shown to be of benefit in reducing heart failure either. There is evidence to suggest that it does bring down albuminuria, but no major evidence to suggest that it can actually retard the progression of EGFR. Of course, the blue-eyed boy for cardiologists this last decade has to be the angiotensin receptor neprilysin inhibitor, sacubitril and valsartan combination. But again, here it improved heart outcomes, but there is no evidence to show that it does bring down renal outcomes. So that's again another space where we are looking for more data. Diuretic, as I've said before, is a double-edged sword. It's absolutely essential to treat heart failure, but it can worsen creatinine and bring down EGFR. The gold standard of treatment of this subset of individuals happens to be agents which are targeting the RAS. Of course, we'll have to keep in mind the hyperkalemia and the worsening EGFR. Attempts to correct cardiorenal anemia have been shown to improve outcomes. Even in individuals who don't have CKD, optimizing hemoglobin does improve outcomes and mortality. Targeting metabolic bone disease is an extremely often neglected aspect of care of these individuals. So optimizing phosphate binders and use of cinacalcet, which is a calcium mimetic to bring down PTH levels, might be something which needs to be made as part of routine care. And some of the newer agents which are in the pipeline, which we might hear about in the next few years, is nesiritide, which is a recombinant form of human B-type natriuretic peptide. And the other agent is serelaxin, which is a recombinant form of relaxin 2. It acts on the relaxin receptor 1 and retards fibrosis at the level of the heart and the kidney. Again, we have to wait for clinical endpoints before these can materialize into use. I've said so much about this vulnerable population with increased mortality, but there is hope and there is scope for improvement in our own practice. And I'm going to end on an optimistic note. So this is a summary of all that we've spoken about, but the optimistic note is about this. This is a study published very recently, which took a look at the effect of an interdisciplinary clinic can have on outcomes related to individuals in this vulnerable population. So all they did was, instead of individually seeing all of these patients, they decided to see them in one space, one clinic, which means if you spend time taking a look at the nephrologist notes and the cardiologist notes, there'll be numerous things that you will find that you can fill in quite easily to improve outcomes. Like, for example, in this situation, this is a graph which is showing you the percentage proportion of patients who are getting RAS blockers. Note that up to 41% of individuals were not receiving RAS blockade in this clinic, right? And once they started an interdisciplinary clinic, there was an increase in the number of individuals who received RAS blockers, to show that there are things that are being slipping right between our fingers, right under our nose, which we can improve upon. And this is again a depiction of the usage of mineralocorticoid antagonists, ACE inhibitors, ARBs, and beta blocker use, all of which seem to improve once they started working together as a team. So, quickly to summarize, yes, individuals with type 2 diabetes are at risk for both chronic kidney disease and heart failure. With the onset of heart failure or CKD, they feed off each other and they can spiral down. But it's important to acknowledge that there is a long arc of intervention points which we can act upon to make sure that they don't spiral down this vortex. And now we might be looking at a space where we might have agents which can improve outcomes both in the cardiac setting and also in the renal setting. Thank you for providing this opportunity, and I hand over the session to the chairpersons.
Dr. Darya, please unmute yourself.
Thank you so much, Dr. Chitra, for your comprehensive talk.